Welcome everyone to today's webinar, Clinical Communication and Collaboration, a new mobile maturity model drives long-term value and ROI, sponsored by Patient Safe Solutions. I'm Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You may submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will send all registrants a copy of the presentation to the email that you used to register. Please be patient as the post-webinar preparation of materials can take some time. At this time, I am pleased to turn the floor over to Si Liu, President and CEO of Patient Safe Solutions, to begin today's presentation.
Thank you, Emily, and thank you everyone on the webinar for joining us today on this very exciting discussion. The topic of today is all around a mobile maturity model framework we like to discuss and share with you in terms of planning for a sustainable mobile and clinical communication platform investment for your health system. We're joined here today by a few of our esteemed partners across our customer base as well as the partner ecosystem. I'll first go around the horn to introduce them very quickly before diving into the content itself. And in the second half of the webinar will be all around the discussion and in a panel format with contribution from them as well. First, we have Steve Shirley, who's the Chief Information Officer of Parkview Medical Center, join us on this panel. And we have Sean Kerrigan, Solution Partner of Business Development at Cisco, focused on the Cisco-Apple partnership. And we have Adam Mahmood, who's the healthcare industry lead at Jamf. And we have Brad Hale, who's the Director of Partner Strategy at Connexall. I thank them all for joining us and sharing their perspective with us today as well. So before we dive into the actual mobile maturity model framework and what is it all about, I wanted to share with the audience a couple of pieces of data we collected from a recent HIMSS analytics survey we've conducted across 300 health system leaders in informatics, IT, and clinical roles. It should probably give you a sense of the current state of their mobile adoption challenges and also progress. So let me begin with the first piece of data from that particular survey. And this piece of data is around what are the three top major drivers for their institution's mobile investment initially. And what we found through the survey is that the top three reasons for them to get into mobile investment and also get into mobile communication investment is around HIPAA compliant secure messaging, voice and secure messaging consolidation, and the ability to route and deliver critical results and alert to the appropriate mobile devices. It's the convergence of these three requirements, at least from the IT side, that led to a lot of the initial first generation and second generation adoption of mobile products into the healthcare setting. And when we surveyed across the rest of the profile, we found that the institutions that we touched, which are across all settings and across all segments of healthcare, they all generally see smartphone as a great opportunity to consolidate a variety of different needs and solutions and applications to move forward with. Over 50% of them have a plan to implement smartphone as an enterprise-wide communication and collaboration device, on top of which they're going to drive a variety of different applications towards. And the next piece of data, and I think hopefully will resonate with the audience on the webinar today, is that what they do feel like the current challenges across the board is the state of devices and modalities and adoption rate can be a pretty fragmented picture. The average clinician persona, if you look sort of on the left-hand side down the column here, whether it's nursing, physician, lab, pharmacist, or the allied health professional team, the average clinician and point-of-care staff can be interacting with up to 5 different modalities of communication and collaboration to get the right context, to coordinate the right solution, and also to execute towards the right steps along their care pathway. And we walked away from that survey. Of course, the survey itself has multiple different questions and have just chock full of meaningful data. If you're interested in getting access to that survey, at the end of the webinar, we have shown a couple of links for you to access our website to navigate around that as well, and we'd be happy to follow up with you separately. In the meantime, after that survey, we got together with our partners on the call. We got together with our key customers and talked about what does the industry need to move the mobile investment mentality, and particularly the clinical communication and collaboration category in general, into a more planful approach versus the ad hoc approach that we've seen over the course of the last 5 years. We wanted to push forward a framework to allow us to assess the current state of mobile adoption in any given health system, and also a framework to help the health system stakeholders to align the disparate people, technologies, and processes internal to them in order to be successful in mobile solution at scale. And what we further wanted to hope to accomplish with this emerging model is by participating in the evolution of this model, inviting industry peers, inviting industry analysts, and also inviting customers to really continue to collaborate around this model, comment on it, evolving it, so that we can move it towards more of a standard over time that are very similar in nature to the HIMSS EMR adoption 7 stages as well. So this model is aiming at, first and foremost, understanding an organization's current state when it comes to mobile maturity and certain capabilities. And secondly is to encourage a more strategic and comprehensive approach to mobile technology investment at scale. Last but not least, hopefully with the launch of this model, we can invite just enough discussion across the industry landscape that we can shift the industry focus towards the financial, operational, and clinical outcomes an organization should expect, and also have the capability to manage too from their mobility investments today and well into the future. Having said that, what are the key capabilities that underlies a mobile maturity model framework? We've assessed through the survey and also the discussion with our industry peer, in general, around 6 unique capabilities in the organization to consider. And of course, we can see each institution may be having a gradient in terms of where they are strong, where they're weak in terms of the relative benchmark into those capabilities. And from these 6 capabilities, we can cascade a level of maturity across the organization, which we'll comment more on towards the end of the presentation. But to go through these 6 capabilities, we have infrastructure management as it relates to what are the infrastructure investment a healthcare system needs in order to support mobile at scale. Mobile device management as a key competency and capability. How do you deal with thousands of devices across multiple care settings and not just inside your hospital? Integration planning. How do you really involve the clinical informatics team, IT team, and your application providers together in a more purposeful integration planning versus the serial or ad hoc approach to integration that we have today? And also application selection. When it comes to mobile, there ought to be a new lens in terms of how to select the right application against the right type of workflow, and inseparable from them is the workflow design component of the capability. We know mobile brings a lot of new metaphor for the user experience, and mobile also brings transformative opportunity for a health system to look at a workflow redesign in terms of how to fundamentally improve the set of outcome, which leads us to probably one of the most important capabilities overall is outcomes management as it relates to the impact of your mobile investment overall. And one way to really approach all 6 key capabilities and also beginning in the very beginning stages of your mobile investment journey, we strongly advocate, regardless of what type of mobile device, what type of mobile application you're currently thinking or evaluating, to pull together IT, clinical, and operational stakeholders together to create a common framework in order to organize the people, processes, and technologies needed to look at mobile at scale. What we wanted the industry to start with is to have a clear mobility charter as a singular, transparent artifact that every level of the organization can reference to and continue to evolve with, that starts with the shared objectives and desired results defined across clinical, financial, and operational outcomes. From those desired outcomes, of course, we know we may not be able to bite off the elephant in one bite, and what are the different workflow mapping and design and sequencing and prioritization we need to be doing, starting with different end user groups, physician to nurse, nurse to physician, to the allied health professional, and ultimately encompassing the entire care team, including the patient. And from the workflow mapping, one can then talk about the integration mapping associated with the workflow mapping. Only then will we encourage the institution to look at a particular application from an end user experience standpoint, from workflow support standpoint, and from a well-integrated product standpoint. With the right application comes the right device selection. That's a whole different dimension of the discussion. As you pick the right device for your choice in scaling your mobility investment, how do you manage the device at scale, how do you provision the device at scale, and how you maintain the life cycle across those devices are also important consideration that ought to cascade, again, all the way from outcomes to workflow to this point in time. And then last but not least, what's the type of infrastructure optimization and maturity model that we should be considering and working with your infrastructure provider and vendor partners to really support a mobility strategy in a common frame versus today the ownership might be scattered in different departments. The approach might be scattered depending on the championship and where it currently resides in your institution. So before we get into the maturity model overall in terms of where an institution may scatter across the different stages, I just want to invite our panelists to join the discussion and highlight their learnings in their travels, in their own institution, and in their customer engagements across each and every single capability. If I start with the first key capability as an infrastructure management, through the lens of mobile adoption, infrastructure consideration ought to include wireless network, telephony systems, data center and security standards, and probably more derivative from those three. I'm going to turn my attention to Sean from Cisco to talk a little bit about, Sean, from Cisco's standpoint and from your customer engagement, what do you see as the most common challenges involved in terms of investing in a proper infrastructure to support the mobile device and mobile application scaling function going forward?
Yeah, great. Thanks, C. You know, as you outlined in your introduction, there are many things to consider in designing a successful mobile strategy. Cisco has seen really good customer success when priority is placed on the wireless architecture and design. So with the increase in the number of mobile devices connecting to the network and the size of data packets traversing the network, designing a scalable wireless infrastructure to support current needs, but also future demand is really critical to maintaining a frictionless user experience. Many of our customers are conducting end-to-end wireless assessments. So that's really looking not only at the wireless infrastructure, but also the mobile devices and the application platforms that are going to be deployed on that infrastructure. I mean, let's face it, we all expect our workplace networks to perform as well, if not better than what we have at home or on the go. Both patients and clinical users expect this. So hospitals really need to deliver on that consumer-based expectation. It's also really critical to define and agree on policies for security, acceptable use, bring your own device, and licensing that meets the overall organizational goals, but also ensures minimum burden on the end user. Equally important is really alignment between IT and the rest of the organization. So oftentimes we see fragmentation between IT and clinical teams, where IT is really looking at an enterprise-wide consideration for technology, and clinical teams or line of business teams are looking at what they need to do today to be effective. One of the things that Cisco has done is partnered with HIMSS Analytics to actually develop what we're calling an INFRAM model. This is an infrastructure maturity model that really looks at the entire healthcare organization, their needs, their goals, and what needs to be implemented from wireless architecture, data center, security, mobility, collaboration perspective. And that's one of the reasons we really like what PatientSafe has developed in the mobile maturity model, because it aligns very well with looking at that larger design and infrastructure to support current and future needs.
Thank you, Sean. In terms of the larger infrastructure needs, Steve, I couldn't think of a better example in terms of a customer journey with Cisco, Apple, and certainly PatientSafe. When it comes to infrastructure challenges, could you share with the audience what you learned along the journey in this capability?
Yes, see, and very quickly to level set for the audience, Parkview is a 350-bed level 2 trauma center hospital. We're located in Colorado, and as C mentioned, the architecture we chose for our mobile-enabled collaborative care team is Apple iPhones as well as the Cisco infrastructure. That's how we drive everything. We started this journey in 2011. So, see, one of the things that we talk about a lot around this hospital is a phrase we use called wireless wellness. We had a very good Cisco infrastructure prior to starting the communications element in the use of our iPhones. And it dawned on us that if users were having difficulty with things like roaming or losing calls or having difficulty with the communications, we were not going to have a success with our solutions. So we actually did something that I will fondly remember for a long time. We brought together for an entire week engineers from PatientSafe, from Cisco, from Apple, my own engineers, plus a couple of different consulting companies that work with various parts of our groups. And we spent the whole week tweaking our wireless infrastructure. And it was just such an exciting time because we started to see things about power settings on access points and various things that we would have never thought would make a big difference. I could tell you that today we average on a fleet of close to 800 iPhones, we average about 2 calls a month for connectivity issues. So that's a big deal. But surrounding that is something that keeps me up at night, and that is multi-vendor configuration requirements. So not long after we did this whole week of work, I found out that we were going to be implementing a new wound care system that uses a really cool laser camera, but it's all wireless. And so, the obvious concern was that we wanted to make sure we didn't go in there and really cause problems with all that work we've done to make the iPhones as robust as they are. So we really have created an atmosphere where every time we add a new piece of equipment, the configuration is done very, very carefully so that tweaks we make to the wireless infrastructure don't ruin another system by making the new system work well. So big deal for us. And then see, finally, and I can't stress this enough because this was a big lesson learned for my hospital, we made a lot of assumptions about our wireless infrastructure, and it's Cisco and it's been rock solid forever. And so we really felt like to move into the comms piece, communications piece, we were going to be just fine with our existing infrastructure. And it became quickly obvious that as part of this whole wireless wellness piece, we really needed to do an upgrade we had planned before we ever started the project. So we actually stopped the project for a few weeks and went in and appropriately did our Cisco infrastructure upgrade. And I can tell you, looking back on it, that's probably one of the most important things we did in addition to that, the week we brought everybody together.
Thank you for sharing that, Steve. And as we move up the stack from the infrastructure piece, an organization's maturity in the selection of mobile devices evolves as they progress from initial reaction ad hoc in terms of adoption into a more planful platform-based strategy. And by extension, the choice of mobile devices also give rise to a key consideration around the discipline of mobile device management. Adam, could you help shed some light in terms of what you see in the space, especially whether healthcare institutions actually see MDM as a competency they need to be investing in today?
Absolutely, C, and thank you so much. We certainly think that MDM, mobile device management, sometimes referred as EMM, enterprise mobility management, is becoming more and more of a discipline in healthcare. If you look beyond healthcare, there was a Gartner report in 2017 titled Critical Capabilities for EMM, and in it, 82% of their Magic Quadrant or critical capabilities references reported running 2 MDMs. In fact, the rest had 3 or more. So certainly in the enterprise itself, MDM is present. Now at Jamf, we wanted to understand the state of the state in healthcare. And so last year we commissioned a survey of our own, pulsing about 600 healthcare institutions around the globe, all different size facilities, et cetera. And the survey results were interesting. In it, 78% of those orgs reported having MDM deployed. So certainly a little bit of a gap from the wider enterprise, and I think something that we see those trends elsewhere as well. Now, what was also interesting in that survey was that 50% of those organizations lacked satisfaction in their current MDM solution. 70% had concerns around security, privacy, and compliance. 90% thought their MDMs could be doing more. So I think as it pertains to MDM being a true discipline, there's still more work to do, and we want to work in this together. Now, as far as the second part of your question, like how do organizations actually get the most out of their MDM? I think it starts by making a strategic investment in an MDM that's aligned with the overall mobility strategy or key strategic initiatives that are in front of us. You want to assess your MDM's partner ecosystem. How do they work with particular device platforms, application providers, infrastructure partners, even peripheral hardware manufacturers, right? Because these things all are important as to how they work together. It's a really popular thought in the industry today around UEM, Unified Endpoint Management, one master tool that can rule them all, if you will. But the reality is that clients are telling us and others in the industry that it's harder than the message. It's not as simple as we see. And unfortunately, I think in those cases, a unified tool kind of leads to a one-size-fits-all approach. And at the end of the day, that can add burden to end users if there are non-native strategies in place. So the message is it's actually okay and good to invest in multiple MDMs that really specialize.
Yeah.
Now, one last point I'd say to just look at your MDM's overall offering, right, beyond just the product. How do they train your teams? How do they support you? What other services do they offer, again, around your strategic initiatives?
Thanks, Adam. Steve, you probably have a unique mobility journey, and could you share with the audience, in light of what you learned regarding MDM in general, and how has having an MDM strategy helped your organization?
Well, see, I would probably call this confession, because the MDM that we had back in 2011, we did have an MDM. It was called Manual Device Management. And so as we embarked on our journey, and this is really a message I would pass to my peers, we really didn't even think about an MDM because it wasn't a big strategy in the hospital to use mobility at that time. And so we chose to manually update all the devices. Needless to say, with 200 devices to start with, my help desk team practically lived out on nursing floors, gathering devices in so that we could do upgrades. So we learned a hard lesson there. But now that we have 800 devices and we're scheduled to go up to 1,200 in the next year, somewhere in that neighborhood, the provisioning, the upgrades, the ability to manage this fleet efficiently and effectively has been proven 10 times over. So I would certainly urge everyone, prior to going into a mobily enabled environment, get the MDM figured out.
Thank you, Steve. And as we move past the MDM side of the capability, when it comes to integration planning with mobile, what role does integration planning play in managing the adoption and proliferation of mobile apps? And I think, Brad, given your work with Connexall and the vast customer base that you interact with, what role do you think integration starts to play in your interaction with your customer, particularly in the context of Connexall as well?
Thanks, C. I think the biggest piece of this is no integration plan really equals no desirable outcomes that are really measurable. No matter if you're starting fresh or retrofitting, resolving workflow and communication pain with measurable outcomes must include a comprehensive integration plan. Time and time again, we see this just not coming together. So uniting existing or net new disparate technologies can be made easier with a validated, and the key word is validated, third-party integration capability. We've all seen a lot of great technologies implemented poorly, and as planning with validation and responsibility often fell short or was non-existent, but it just doesn't have to be the way. It is imperative, and what we see constantly where success has shown through is that by using only an enterprise-grade approach is the right strategy. Validated infrastructure, edge to core, is key. You can't, the comment earlier from Sean around, the expectation from a consumer expectation, what you have every day, but consumer technology isn't going to give you the solution. Validated devices, these are devices that are going to work in your healthcare system, so they better work. And really looking at a CWNA type design, which is exactly what we're seeing from the likes of Cisco, where there's calculated outcomes and performances around the infrastructure. And then wireless voice and data, they are really very different. In some cases, voice is not for the faint of heart. So voice with data truly needs validation to ensure end-to-end success. I think insisting on vendor responsibility is key. All too many times, this is where where it fails. as well. Really, who owns the success and failure of the project, of the infrastructure, of the validation? Is it you, the hospital itself? And what does failure look like? And what does it really mean? So what are the level of risks that you're willing to take? You can't just throw this stuff in either, right? That's when we get back to this enterprise grade perspective. You can't throw it in and expect it to work. It's just not possible. And oftentimes or not, this is really when Murphy shows up, right? When we don't have those vendor responsibilities, that promises are made and not kept. And having a partnership, and this is, there's several partnerships in a deployment and an integration plan. One hand to squeeze or multiple vendors who own their own end and stay, and stay in their lane, but work with everybody at the same time. One vendor with all elements is difficult these days. Not typically doable, but with partnership ownership, then very doable. And sometimes that one vendor is going to bring multiple elements and has it all figured out. So it's just ensuring that it's there. And then there's the multi-vendor, that one to several elements each. This is a little more challenging, but there is times and lots of success, and it's when best practices and certifications and validations are all complementary to the vendors. So everyone's working together in the same mindset, not only for the client, but to ensure technology is deployed and implemented under the integration plan, from a best practices standpoint. And then several facilities that we've seen try this, right? They've had both. And so it's a mixed bag. So there is a lot of different ways to approach it. And I think the straw that breaks the camel's back, is ignoring the best practices, really, strengthening your integration plan with that. And look to those who have demonstrated success in the past. And there's lots of great examples of really great implementation. So ask for proof from your vendor, looking for the truth at the end of the day, and really copying what others have done successfully as part of that plan, I think is a great element of success.
Thank you, Brad. That's a pretty comprehensive view of integration, and sort of take integration as a broadest sense of the term. And Steve, when it comes to integration planning in particular, what approach did Parkview take to managing the volume of the mobile apps and also planning for the integration of these into the clinical and IT infrastructure?
So, I'm going to take a little bit of a hospital approach to integration and just mention three things. First and foremost, we're very fortunate because we have the opportunity as a hospital with a leadership group that understands the critical nature of integration between clinicians and IT. So we have IT representation at every physician meeting in the hospital, medical exec committee, trauma committee, on and on and on. We build relationships all ongoing all the time with our doctors and nurses. So that's huge. The second piece is we have a technology steering committee. So it's a rule in the hospital that no rogue purchases occur and that any new software system being proposed must go through technology steering. And technology steering is made up of a multidisciplinary group. So it's got every different area, pharmacy and lab, and everybody else involved that helps us to make great decisions. So that's a huge piece of our integration plan. And then the final piece is something we call NFL, Nursing for Leadership. And so, as we start to look at any new system, all of this really the governance and how we're going to move forward with this goes through the Nursing for Leadership group, which is made up of all of the nursing leaders in the hospital. Once again, IT's at the table. We do all of the analytics for the different systems we put in, and those get presented to Nursing for Leadership so they can really evaluate if they're using the product right and if we've integrated it appropriately into the hospital.
Thank you, Steve. And as we think about integration planning, it's probably inseparable from the workflow design piece of it. Workflow design consider each user persona on your care team that could cut across communication, documentation, and coordination tasks. Advanced organization actually include patients and their family in the planning of the workflow design as well. In terms of what role does workflow design play in the mobile adoption strategy, Steve, what are your lessons learned there from a workflow perspective?
Well, see, some of my peers on the call and I probably all know the famous saying that new computer systems don't fix broken processes. So, I think what's really foremost in our minds here at Parkview is that anytime we're going to look at a new system, we first go in and assess all the workflows as if computers didn't exist to understand how the clinicians are moving through those workflows. We brown paper map, we do value stream mapping, a lot of things to help us to understand exactly what their processes are. We've been very successful at that because it helps us to really stop from repeating what's currently in place. Another thing that I think is critically important in this area is as we're building workflow and as we start to work with a system, the training and education piece become paramount. And so many of us will set up a training and every nurse gets 2 hours of training, let's say, and we call it good. But we work a lot with the laws of diffusion of innovation here at this hospital and get that there are innovators and early adopters and late majority, early majority, and laggards. And so we really feel it's important to come up with a variety of ways to train so that people can train in ways that work for them and are comfortable for them. That's been hugely successful. And I think finally, see, the thing that we do as we look at workflow is when we really establish what we think the workflow design is going to look like, we go back and meet with the clinicians and literally show them the maps, walk through it. We actually have simulation software we use that helps us to walk through this. And we really validate that we believe the workflow will be successful as we work through the new system.
Thank you, Steve. Brad, what about your experience with Connexal's customers when it comes to workflow design capabilities?
Well, see, workflow design is kind of right in our wheelhouse, and I think is really foundational to what we do. The workflow design processes are really truly intended to discover and bridge the gap between the current process and the future state. So to Steve's point, striving for 100% current clarity, if possible, is critical. Patient care in hospitals calls for a tight coupling of the work processes across all teams. There's a need for high level of interdependence between many care team members from many different backgrounds, departments, and disciplines. So again, even to what Steve was just mentioning, it really does suggest that a technology steering committee or like is important to align with everything. In most cases of patient flow and throughput, work is carried out in isolation and not through true collaboration. The sharing of knowledge and resources across all team members sometimes doesn't happen, but again, is critical. And so the reality is that it's hard to have working relationships across functional teams. Shared knowledge is not often, but is foundational. And engaging cross-functional team members is critical to ensuring the new flow delivers on all levels, the right information to the right person at the right time. And then, tweaking it and really making it work. One of our customers assigned an internal team member who shadowed their OR team across 11 existing OR theaters. And prior to moving to a new build with 19 OR theaters, that individual did that for 2 months. And in doing so, they really understood what their new workflow could or should look like. And it was completely redesigned from their old. In doing this, they were able to guarantee and truly see 100% positive acknowledgement of all alarm and alert notification. They had a 70% decrease in their response times, and they had elimination of false or duplicate requests. But the big ticker for them was that they saw an ROI that was north of $15 million over 5 years. So it really paid for itself by working through the workflow.
Thank you, Brad. Those are some powerful examples of what a workflow design done well will bring you. Sean, from Cisco's perspective, what's the interplay of workflow and infrastructure design? How can health systems sort of provide for both and bridge those two disciplines together?
Yeah, that's a little bit like asking which came first, the chicken or the egg, right? They really are interdependent on each other. And what we're seeing is that from a preventative to specialized care perspective, technology really is what's empowering those care teams to become more effective and efficient, overall improving the care coordination and collaboration. But that said, to Brad and Steve's point, conscious workflow design is really critical to improve the efficiency of those existing work processes, and that the effects of decisions by an expert in one role will have a downstream effect to others. So all roles really need to be considered in that workflow design. But optimal workflow design is really only as effective as the technology that supports its delivery. So we saw this recently with a mid-sized health system in Kansas, where they had a very well thought out workflow design and found an app to support those goals. But when they launched that, their new workflow, it just failed miserably. They were experiencing multiple disconnects, which created friction in the workflow and user experience, and so they saw very low adoption. I think we all know that in nursing or in clinical cases, if something doesn't work the first time, they're going to set it aside and go back to old processes. So we consulted with that customer and made the recommendation that they perform a full mobile assessment of their wireless infrastructure, evaluating both the wireless architecture, the mobile device platform and device that they chose, as well as the application. When we brought all three legs of the stool together, to Steve's point earlier, and completion of the assessment, they selected a new mobile platform and device, and they were up and running with a successful rollout within weeks, with the nurses fully adopting the system. So that mobile platform, device selection, and really considering a secure, intelligent network platform to deliver that optimal performance is really critical and keys to the success. So in summary, you can have a great workflow, but if the technology you're running that workflow on isn't optimal, then you're going to fall over sideways.
Thank you, Sean. That's a very helpful perspective to hear from infrastructure players' perspective, how to really sort of straddle for both. And when it comes to application selection, the sheer volume and variety of mobile applications available in the healthcare landscape can be quite overwhelming. An organization's mobile maturity also depends on some degree to which type of consideration of end user experience needs to be influencing application, and also how to prevent inadvertent degradation and accidental fragmentation that we've shown earlier on in the HIMSS analytics data. Adam, maybe from your perspective, we can start on a MDM player's view of who do you see as the most frequent driver of mobile app selection in an institution in all the clients that you have been dealing with lately?
Yeah, sure, C. As an MDM, our conversations traditionally over the past 15 years have started with IT. So many times when we've heard about an application, it's always from them. Now, I've been reflecting back on this after working with you and the rest of the team, and it's really clear when IT teams were aligned with the other individuals in their orgs and truly understood, desired outcomes and workflow for a project, and other times when they were just told, hey, here's an app we need, let's figure out how to go deploy it. I think those are two really different things that yield different results. So, my advice would be much in line with what you're hearing from Steve and everyone else, align people. The more your MDM teams know about the larger picture objective, the better they can granularly deploy and configure that application on a device. For example, in the Patient Touch app, there are different configuration flags as Jamf pushes that app to a device. Those can be very different end functionalities. So we all need to be aligned is the message.
Thank you, Adam. Steve, from your perspective, what was Parkview's approach when it comes to mobile app selection against impending force of proliferation of more mobile apps as well?
Well, see, we have a very much a standardized process for selection here at Parkview. We've been very fortunate to find some really highly qualified project management folks. And so for every single project that I already mentioned, we go through tech steering, but for every single project, we develop a project charter. That's scope, what's in scope, out of scope, who are the various players in the project. We even look at risks. And so quite often we will go to the clinician side and say, here's a risk. If you guys are not right by our side all the way through this project, we won't succeed the way we could. So we work through all of that. Then we do an RFP, request for proposal. We send that out to 3 to 5 companies, and typically we build the RFP so that the clinicians will provide us with the feature functionality set that they're interested in. IT takes care of all of the other things like how the company looks financially, what their internal controls are, how they install software, how they train on software, how they support software. We even have a section on if we were to work with you, would you accept these contract stipulations? So we work through all of that. We also then use a weight-based matrix. So we ask our clinicians to weight either a 1, 5, or 9, the things that are least and most important in the feature set. When we get all the information back, we go out and evaluate, create what we feel are the top 1 to 2 to 3 candidates for the system. Then we do demonstrations. We bring everybody in. Most importantly, once we find the final candidate, we go out and do site visits. So that process is required on every project we do. Again, like I mentioned earlier, multidisciplinary teams have to be involved. We have the pharmacist, the phlebotomist, or the lab, whichever who might be. We've got radiology. We've got everybody sitting at the table as well as clinicians, and so that creates success. Integration partners is so important to us. And, you know, I can say that as we've done this mobile journey we've done, having Apple and Patient Safe and Cisco as our partners has, I wouldn't say it's guaranteed us success, but I can't think of a finer group of folks to work with in terms of giving us a chance to be successful. And then I said it before, Steve, but we just really have a steadfast rule around here that no rogue purchases are allowed. What I like to tell folks is if they come in and say, I bought a piece of software, I like to ask them which paycheck they'd like me to take it out of. So we're very, very much strongly against those kind of things. And then finally and lastly, again, overemphasizing this, but when we build great relationships with our physicians in particular, but all clinicians, we see great, great, great success. And so very important is our application process.
Thank you, Steve, and we certainly appreciate that perspective as well. When it comes to the ultimate outcomes of a mobile investment and a mobile strategy, we've seen outcome definition include financial, operational, and clinical metrics. We've seen the continuous monitoring and ongoing optimization becoming more of a cornerstone for a very mature approach to mobility. What role do you see outcomes management play in the mobility strategy planning phases? Steve, and what results have you seen at Parkview from your outcomes-driven type of lens with your nursing leadership and with your operational leadership as well?
So I think the most important thing here, C, is that our clinical informatics team, and at Parkview, clinical informatics, all of our nurses in that team are a division of IT, so we work as teammates on this deal. But clinical informatics runs all of the analytics, and so we made that a very, very focused effort as we started to deploy our mobile strategy. But just a couple of numbers to tell you what success we've had. We had a 60% decrease in med admin errors. We had a pretty low rate anyway, but as everyone knows on the call, when you reduce your med errors, you've certainly made a great change for patient safety. We have 100% bedside specimen collection labeling, and that's an incredibly important one because in the old days with the old workflows, we would have to get specimens down to the lab with a piece of tape on it or whatever to get it labeled. Now we have printers and we label right at the bedside. We're 100% in that area. In terms of what we've done with our HCAHPS, we've seen about a 210% increase in our HCAHPS scores as it relates to communication and especially med education. That's been very, very important for us. And I think, see, the one that I love the most is our analytics team figured out a way to look at what kind of time we were saving a nurse by having a mobile system for them to work off of. And our calculation yielded, and what we're seeing is that the average nurse gets about 60 minutes more per day at the bedside. We're a Studer hospital, and so we believe that every moment a nurse can be at the bedside talking to a patient, holding their hand, working with them in some fashion, we're going to have better outcomes and certainly going to be more successful. So that's been very, very big for us. And we continually ask the nurses to give us their perspective. My own daughter is a nurse here at the hospital, and so I actually get more perspective sometimes than I ask for, but it really helps us to be very clear that we're addressing the needs of what the nurses are after.
Thank you, Steve. And Brad, from Connexol's customer interaction perspective, what was the implication on mobile and integration planning and all the workflow design and its ultimate impact on outcomes management?
Well, from a Connexol perspective, I mean, just in general, how do you follow Steve, right? I mean, that's amazing, the outcomes that they've seen. And we're seeing more and more of this because the whole outcomes management aspect is paramount. You alluded to that even earlier, C. You know, it's critical to define these desired outcomes ahead of time and then really apply those desires upstream, you know, proactively with all the vendors, even ahead of acquisition to ensure, you know, ultimate success. This especially holds true for mobile strategy, right? From infrastructure design, including, you know, human traffic areas and flow, wireless data flow, et cetera, to device decisions. I mean, application integration, including EMR and the many disparate offerings by the ward, it's critical. And in the end, the success of a mobile strategy really hangs on whether or not the solution is actually adopted and used. So using outcome management, outcomes, I should say, to driven model, I apologize, using an outcomes-driven strategy. You know, we've seen our clients results like what Steve had talked about, right? So I can give you a couple of examples where, you know, transporter task completions were done in 20 minutes. That was a 44 to 70% task completion with pure guidelines. 58-minute to 15-minute completion time. I mean, just staggering changes when you're really managing those outcomes. Patient order ready to patient ready for pickup. We saw that in one client decrease from 103 minutes to literally 15 minutes. Patient waiting time, outpatient flow systems, you know, decreased from 225 minutes to 150 minutes. And distracting alarm reduction across 7 units in one facility. We've seen suppression of 46,000 alarms that did not have to be sent for one reason or another, which was a 34% decrease. And so from alarm fatigue and the outcomes from that, it's staggering. So if you're able to manage those things, you can absolutely change the way you manage your business.
Thank you, Brad. And that's certainly what we've seen as well as the industry mature towards an approach and not treat mobile as a departmental investment only. With that, first of all, thank you all on the panel for your valuable input across all the 6 key capabilities. And what we would like to show the audience on the webinar a little bit is in terms of what are the different stages of the mobile maturity model once we come up with an assessment and the scoring of the 6 key capabilities and benchmark that across some of your industry peers. First and foremost, you can see that as we assess these 6 key capabilities, it will help us understand an organization's relative mobile maturity, starting with stage 0, which is the default state of most organizations, let's say 3 years ago, whereby the mobile investment may be single-purpose secure messaging, quite fragmented in pockets as the institution and rather ad hoc in terms of its rollout strategy. And there's really no planned enterprise-wide visibility that's a true cross-functional collaboration. An organization generally progress from the fragmented and reactive approach towards a more managed and scalable program as the ultimate pursuit all the way to stage 4. And along this progression path, they discover what are the people, process, and technology requirements in each of the 6 aforementioned the capabilities. And today we find a lot of the institutions are currently in a stage 2, which is they're in a single purpose mobile app adoption that drives around a lot of the questions and inputs and inquiries around each of the 6 key capabilities we discussed about. And pockets of the organization do see early traction with that. Workflow integration with the full care team is still a gap and a challenge. What we hope to move the industry towards is between a stage 3, stage 4, but ultimately really want to start with a desire for a truly managed and scalable mobility program where we have an enterprise-wide strategic initiative, strong cross-functional visibility, and also outcomes targets are consistently monitored and actually achieved regardless of which application you're using. And that translates into a clear charter, like some of our panelists discussed, and that translates into a more purposeful strategy that could be sustainable so that rework and repurchasing and sort of a do-over related to mobile doesn't happen as often as it did over the past 2 years across the landscape overall. There is a full list of questions behind each capability, and there's a scoring system behind the capability that translate into the mapping of the different stages. Before we go into Q&A, I'll just say that for anybody on the webinar interested in getting access to the full white paper, the full framework a little bit, you can log on to our website at the following link to take a look. And, right now I'll turn over to the audience section to start submit all of your questions to our presenters. And you can submit into the space label, enter a question for staff, and we'll get through as many of these as we have time for the remaining 5 or 6 minutes on the Q&A session. So I see the questions are starting to stream in. Maybe I'll begin with the first question, sort of the first in, last out kind of approach here. Steve, this question is addressed to you. What did Parkview do exactly to optimize your wireless infrastructure initially, and who from your team actually manages it on an ongoing basis, given that this is a living, breathing thing?
So great question. One of the things we've done is we have an engineering team here at the hospital. We also have an outside consulting firm that we work with to try to help augment what we do here. And so when we worked through our initial stages, as I mentioned, we had all of the companies come together, and it was really quite eye-opening to get a Cisco perspective versus an Apple perspective versus patient safe. But we moved through all of that. As we move down the road, all of our engineers, on-site engineers, manage the wireless infrastructure from day to day. So on a periodic basis, we'll bring the external consultant in to make sure that everything still looks healthy, but we really like to see that internal group have that management capability.
Thank you, Steve. And the next question in the queue was, how does your common framework for organizing people, process, and technologies actually ensure we can put the patient at the center of the model? And I'll take that question because we've been doing a lot of the similar discussion with clinical leadership as well. Fundamentally, when we frame the desired outcome and for the entire mobility charter, we must include a patient experience side of the design. What do we want the patient to experience from a much less noisy patient care environment? What do we want the patient to experience in terms of the efficiency with which they receive their care, the timeliness of the care, and also their overall HCAHPS categories overall? Once you can put a design team together inside your healthcare institution that focuses on patient experience, nursing processes, and physician collaboration with the right IT partners and counterparts on the other end, that's where the charter ought to begin, which is workflow, outcomes, and patient experience as the guiding light. And from that, you can define the different workflows that you want to embark upon with your mobile investment of choice. Hopefully that addresses it, and we'd be happy to follow up with you after this call as well. So I'll go down the question queue here. The next question is, how did you get the voluntary physicians with BYOD to get on board with installing MDM on their personal devices? So Adam, I think I'll direct that question to you.
Yeah, I think many MDMs do that differently, but the best path is one that tries to quell any fears that an end user has about what MDM can and cannot do. So in some products, that's just made visible. When you're going through this user-initiated enrollment process, I visit a website that IT or another team provides to me, and when I go through that process, I see exactly what will or will not happen with my device.
Thank you, Adam. Next question in the queue is, how can you provide or prove HIPAA compliance when actually trying to communicate between in-hospital staff with outside labs, pharmacies, and ambulatory physician offices? I'll take on that question since we deal with that a lot, especially with increasing volume lately. one of the key things is to make sure that your vendor of choice when it comes to mobile workflow and mobile communication can show you the proof in their capability around HIPAA audit trail and also around the capability to send non-PHI secure SMS paging and SMS messaging capability when you go from within the HIPAA compliant trail to outside of that particular trail, in particular giving you the secure portals to link into and show the audit trail and show the compliance on the series of interaction from there as well. Then the next question up in the list is what type of roles have been included as decision makers in the most successful enterprise mobility rollouts that you've seen? And Brad, I know you deal with a lot of our peers in the industry group, so you're probably well equipped to see what are the most successful mobility rollout that ConnectAll has seen out there, and typically what type of decision maker by role are typically involved together.
Wow, that's boy, it's a really a mixed bag, and I don't mean to be so general about it, but you know, we really see that from hospital to hospital, those individuals can be quite different. I think you know, it was commented before in the presentation when, and I think it was Steve that mentioned it in terms of the roles that they have in playing in the decision-making criteria and in the in the workflows that they're doing. Come from different levels and people buying in, and we really believe that you have to have that ownership. If it's a clinical workflow strategy, the ownership has to be likely starting at the CNO and then working its way down through those groups and getting those individual groups buy-ins. The way certain things happen on one ward versus another, depending on discipline, could be quite different. And so that need to work with those individuals that truly do own that workflow in those areas or in a different building in a different situation needs to really be investigated heavily. And then once you understand that, you can apply that into how it's going to be presented on the mobile device. What the traffic flows look like, how people are operating, do we have the right infrastructure? All of the elements that we've discussed as a team through this presentation come together almost well orchestrated, and then I think you start seeing success. And again, the initial rollout of this might be okay. It may not be perfect. And I think perfection is often difficult to see early on, but then it's just working again with those teams over and over again to ensure that using analytics to go back and reevaluate, retune a workflow design, and again just getting that buy-in on the mobile device, because it's clearing the confusion, right? You really just need to ensure that you've got all of those elements taken care of, and then you'll start to see the clinician, if you will, or the other individuals not only buy in, but it becomes another appendage that they have. They become very powerful in what they're able to accomplish at the end of the day.
Yep, and to add on to that, in PatientSafe's world, what we've seen as the most successful at-scale deployment, the governance committee for that enterprise-wide typically would have a chief nursing informatics officer or a chief medical informatics officer as the main champion that can bring together IT and clinical side together and their associated team with key, highly visible sponsorship throughout every level of the organization from the CIO and the, particular either a CNO or CMO of choice to go through that process with sort of key frontline champions identified as sort of evangelists for this program as a core part of the governance group across IT and clinical as well. And that sends a clear message to the whole institution that this is not an ad hoc adoption. This is a full enterprise-wide initiative with workload implications, with integration implications, and certainly with a mind towards outcome. So with that, I know we're coming up to the top of the hour, and that's sort of the full extension of the hour that we have together. I appreciate our panelists, and I appreciate the audience, and I'll turn it back into our Becker's colleague to wrap up as well.
Thank you so much. So that's all the time we have today. I would like to thank Steve Shirley, Sean Kerrigan, Brad Hale, Adam Mahmood, and C. Lou for the excellent presentation today, and to our audience for participating. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.